नहीं हुआ है, नहीं हुआ है।
Good evening, everyone. Shall we begin?
Good evening, ma'am.
Or do we wait for more participants to join?
Okay, ma'am.
No. I mean, what is the consensus of the house? We have 22 participants as of now. So, and it's 9:05. Should we get going?
I think we can wait for 1 or 2 minutes more so that more people can join.
All right. All right.
Ma'am, can we start now?
Yeah, sure. So good evening, everyone. I'm Dr. Somalika, Assistant Professor Neonatology at ABVIMS and Dr. RML Hospital, New Delhi. So we thought that hypoglycemia is a very common presentation for neonates in our NICUs or postnatal wards. And many a times we are encountered situations where we investigate and we end up with hyperinsulinemic hypoglycemia. So we thought with the help of a couple of cases as examples, we can go into the review of to what extent these babies need to be evaluated and investigated, and if so, when, and what are the possible etiology causes and how to proceed in diverse etiologies. So I would like to invite Dr. Moiz, who is a second-year DM resident at ABVIMS and Dr. RML Hospital, to kindly present the cases in this series. Over to you, Dr. Moiz.
Thank you, ma'am. Good evening, respected seniors. Good evening, teachers, seniors, and colleagues. I will be presenting a clinical club today. The topic is hyperinsulinemic hypoglycemia, and I will be first discussing the cases and the overview and the causes of resistant hypoglycemia, and approach will be taken up by Dr. Dipender. So let's start. We will discuss this seminar under following headings: 2 case summaries, then definitions by reputed bodies, then overview of glucose metabolism, causes of persistent hypoglycemia, then what's the pathophysiology and management. So our first case was baby X, DADC 2-in-1, was born to primary mother at 38 plus 2 weeks with a birth weight of 1810 grams. Baby was SGA via LSCS. Elective LSCS, was born through MSL, non-vigorous baby, and required resuscitation at birth in the form of PPV. The APGAR score were 2, 7, and 8. Other twin cried immediately after birth was a male baby with a weight of 2400 grams and is also a SGA baby. Significant antenatal history is mother is having gestational hypertension, and she was on oral labetalol. So on admission in the unit, the vitals were stable. In head-to-toe examination, there was no dysmorphic features, no midline defect. There is decreased muscle bulk and subcutaneous fat. Rest of the systemic examination was remarkable. So, course during hospital stay. On day 1, baby developed asymptomatic hypoglycemia, which was detected on routine screening as babies SGA. So we do routine screening of these babies. At 2 hours of life, the RPS was 22, and GIR was started at 6 milligram per kg per minute. Over next 1 to 3 days, there was a fluctuating GI requirements ranging from 6 to 12 and RBS level. However, baby remained asymptomatic, was on IVF for GIR and oral feeds. By day 6, the GIR requirement went up to 14 milligram per kg per minute. So critical samples were sent. Serum insulins, cortisol, urinary ketones was negative, and blood test was normal. We got a ammonia level of 67, which is within normal limit. The lactate level was raised, but subsequently we did a repeat sample and we find that lactate levels were normal. Cortisol was also within normal limit, but we got an insulin level of 2.4 milliliter unit per ml, which was raised, and TMS and GSCMS was unremarkable. So, in view of persistent requirement of GIR, so diazoxide was started on day 9 at a dose of 15 milligram per kg per day orally in 3 divided doses. By day 14, baby was euglycemic. The GIR was gradually tapered and stopped, and baby was on oral diazoxide. On day 15, diazoxide was withheld in view of baby developing late onset sepsis and septic ileus, but RBS monitoring was continued. After 48 hours, baby again developed asymptomatic hypoglycemia, which was requiring a GIR from 6 to 8. On day 19, as we have started oral feeds again, so diazoxide was reintroduced. By day 22, baby was on for oral feeds, normoglycemic, and GIR was gradually tapered and stopped. By day 28, the diazoxide was also tapered to 10 milligram per kg per day. This is a graph showing GIR on various days of life and at what are the points where critical sample was sent and diazoxide was started and when GIR was stopped. So by day 32, baby remained euglycemic, so diazoxide was stopped. Then by day 38, by day 32, baby remained euglycemic. By day 35, baby remained euglycemic on exclusive breastfeeding. Then the neurologic examination was normal. Weight at discharge was 2300 grams, and baby was gaining weight at an acceptable level, and the baby was discharged. Follow-up after 2 weeks, the neurologic examination was normal, and MRI brain was awaited. Final diagnosis: DADC 2-in-1, term baby, SGA less than third centile, prolonged and resistant hypoglycemia, cause hyperinsulinemia. Then our case 2, baby Y, male baby, product of non-consanguineous marriage, born to 4th gravida mother with a para 3 and live 1. At 36 weeks via LSCS with a weight of 3500 grams. Baby was LGA, cried immediately after birth. In significant antenatal history, the mother was on GDM, control on diet. And there was also history of one prior sibling death. Baby died on day 1, cause unknown. History of one stillbirth at 33 weeks, cause unknown. And a living sibling, a 4-year-old male baby who was neurologically normal. So this was an outbound baby, and our previous case was our inborn baby. So this baby, the course outside in other hospital prior to admitting in our hospital was baby developed asymptomatic hypoglycemia after birth, was started on GIR. The maximum GIR reach was 16 milligram per kg per minute. The critical samples were sent on day 7. The insulin level was reported back as 28 milliliter unit per liter. Cortisol was normal. Urinary ketones was absent. Urine reducing substance was also absent. Baby was given a trial of diazoxide at 10 mg per kg per day for 5 days, but there was no response. And baby was also given nifedipine for 3 days, but discontinued in view of no response. Genetic testing was requested on day 12 in the form of hypoglycemia exome sequencing. And baby was referred to us On day 15 of life, clinical course in our hospital, baby was admitted on day 15. The admission vital was within normal limit. There was no dysmorphic features, no midline defect, and there was no feature suggestive of Beckwith-Whitman syndrome. So on day 15, we continued GIR of 10 milligram per kg per minute. On day 17, GIR requirement went up to 16 milligram per kg per minute. The serum insulin was reported back as 14.24 milli-IU per liter. Cortisol was normal. Blood gas was normal. Urine for reducing substance again was negative. Urinary ketones was negative. GCMS and TMS was unremarkable. So we have given a trial of diazoxide again at a higher dose of 15 mg per kg per day. By day 23, the GIR was 12 mg per kg per minute. Diazoxide was stopped as response was not expected, and Dotanac PET scan was requested from AIMS, and octreotide was started at 5 microgram per kg per day subcutaneously in 3 divided doses as subcutaneous injections. By day 27, the PET scan report has no lesions shown in relation to pancreas, but they have reported a paraganglionoma at the level of L5. Baby was still on a GIR of 12 mg per kg per minute. The octreotide dose was increased to 12 microgram per kg per day. By day 38, we could not find an association between hyperinsulinism and paraganglionoma in neonates. We did an extensive literature search, but we couldn't find association between the two. And more so, paraganglionoma was reported in older children, and they present with some of them, not all, present with symptoms of catecholamine excess. And we have also discussed this case with the pediatric endocrinologist, and they were also of the opinion that this is an incidental finding, and it is not an insulin secreting tumor, because paraganglionoma was never reported in literature as secreting insulin, except we got a one case report from Turkey, in which paraganglionoma as a source of insulin was reported in a 67-year-old female lady. Genetic testing report was still awaited. By day 40, octreotide dose was increased to 16 microgram per kg per day. The GIR was gradually tapered and stopped, and baby was euglycemic. So this is the report of gallium-68 Dotanac PET scan, which is showing this is the paraganglionoma at a level of L5. These are the images showing paraganglionoma. By day 42, we got a report of a hypoglycemia panel exome sequence, which reported back as homozygous autosomal recessive ABCC8 mutation. By day 47, depot octreotide preparation was started, IM, along with subcutaneous octreotide. This depot preparation need to given a monthly. But there is need for an overlap by subcutaneous injection for at least 1 month, so that depot preparation can take over. And so we have taught attendants the technique to give subcutaneous injection at home, and also we also taught them how to maintain home blood glucose monitoring diary. And baby was discharged on subcutaneous and monthly depot octreotide preparation. The pre-discharge neurologic examination was normal. On follow-up, a baby was euglycemic on depot octreotide only, and neurological examination was within normal limit. The MRI brain was awaited. So final diagnosis: single, late preterm, 36 weeks, LGA, resistant diazoxide, non-responsive hyperinsulinemic hypoglycemia, cause familial 1 ABCC8 gene mutation, and paraganglionoma. So we have discussed these two extremes of hypoglycemia, one presenting in SGA baby, and other presenting in LGA baby with a different cause in that two babies. So now I'm handing this presentation over to Dr. Dipender to discuss further the overview and approach and management to hyperinsulinemic hypoglycemia. Over to you, Dr. Dipender. You are now host.
Okay. Now I'm going to present definition. And according to American Academy of Pediatrics, in first 4 hours, is asymptomatic hypoglycemia defined as blood glucose level less than 25 milligram per dl. In 4 to 24 hours of life, blood glucose level less than 35 milligram per dl is called asymptomatic hypoglycemia. And symptomatic hypoglycemia is defined as blood glucose level less than 40 milligram per dl. And according to Pediatric Endocrine Society, within 48 hours, asymptomatic hypoglycemia defined as blood glucose level less than 50 milligram per dl. And within 48 hours of life, blood glucose level less than 60 milligram per dl is called asymptomatic hypoglycemia. But symptomatic hypoglycemia, there is no clear-cut cutoff. But according to WHO, blood glucose level less than 45 milligram per dl is called hypoglycemia. And recurrent and resistant hypoglycemia, when infant fail to maintain normal blood glucose despite GI of 12 milligram per kg per minute, or when stabilization is not achieved by day 7 of the therapy. Glucose metabolism at and after the birth. And after the birth, there is a cessation of the maternal glucose supply. So counter-regulatory hormone will be increased, that is glucagon and catecholamine. Catecholamine, which increase glycogen breakdown and gluconeogenesis from the amino acid and fatty acid metabolism. And other hand, there is a decrease of the insulin secretion, which causes decrease in glycogen formation and decrease the peripheral utilization of the glucose. So normal blood glucose is maintained in the neonate. And in the neonate, there is an increase of the glucose requirement due to the high brain to body ratio. Cause of neonatal hypoglycemia. There is two parts: hyperinsulinemic cause and normal insulinemic cause of neonatal hypoglycemia. In the hyperinsulinemic cause, there is transient or other is persistent or recurrent. In transient, infant of diabetic mother, intrapartum dextrose infusion into the mother, stress in peripartum and postpartum period, trauma, asphyxia, hypothermia, and SGA baby. The persistent or recurrent cause are ATP sensitive potassium channel defect, GLUT1 activation mutation, that is glutamate dehydrogenase enzyme, HADH mutation, hydroxyacyl dehydrogenase enzyme mutation, glucokinase activation mutation, hepatic nuclear factor 1A and hepatic nuclear factor 4A mutation, uncoupling mutation, and then syndrome, Backus-Winkelmann syndrome. And other part of that is normal insulinemic neonatal hypoglycemia. Transient cause are developmental immaturity in adaptation to the fasting, that is prematurity in SGA baby, increased metabolic expenditure, that is sepsis, erythroblastosis fetalis, polycythemia, maternal condition, that is toxemia, administration of prophylactics, and persistent or recurrent cause are hypopituitarism, primary adrenal insufficiency, inborn error of metabolism, glycogen storage disease, disorder of gluconeogenesis, defect in fatty acid catabolism or ketogenesis, organic aciduria, galactosemia, and hereditary fructose intolerance. And epidemiology wise, the cause of hypoglycemia prematurity is generally most common cause followed by IDM, septicemia, parental asphyxia, stress, and neonatal hyperinsulinism in 1.9%. And the incidence of congenital hyperinsulin 1 in 40,000 to 25,000. 40,000 in European country, 25,000 in a Arabian country. And the most common cause of the congenital hyperinsulinism is most common is ATP potassium channel mutation. Second is GLUT1 gene mutation. Third is glucokinase enzyme mutation, and other are each account for 1 to 2%. insulin. Now going to discuss insulin secretion pathway, and this pictorial diagram showing the ATP sensitive potassium channel. This ATP sensitive potassium component are generally made of the two component, pore forming component and regulatory component. Pore forming component is made of inward rectifier channel 6.2 that encode KCNJ11 gene, and the regulatory subunit, that is sulfonylurea receptor, is coded by the ABCC8 gene.
Sorry,
So
I should.
when the glucose is entered through the pancreatic beta cell through the GLUT2 receptor, and the glucokinase enzyme act to the glucose, which convert in, which activate the, which increase the ATP by ADP ratio in the beta cell of the pancreas. When the increased ATP to ADP ratio in the pancreas, which activate sulfonylurea receptor, are finally block the pore forming. So potassium, ATP sensitive potassium channel will be blocked. So potassium content in the beta cell will be increased. So it causes depolarization of the cell, and after depolarization of the cell, which activate calcium channel, and activation of the calcium channel, influx of the calcium into the cell, and calcium will be increased the cell, which increase insulin released by the exocytosis. So any factor which increase ATP by ADP ratio in beta cell of the pancreas, which increase the insulin. The other mechanism, when amino acid, that is glutamate, it convert into alpha ketoglutarate by the glutamate dehydrogenase enzyme, which also increase ATP and finally increase the insulin level. And other substrate that is a fatty acid through the short chain hydroxy-acyl coenzyme A, uncoupling protein HNF4 alpha and HNF1 alpha. The exact mechanism of HNF4 alpha and 1 alpha is not known. Why increase insulin in this? And type of hyperinsulinemic hypoglycemia. In prolonged hyperinsulinemic hypoglycemia, the SGA baby generally develop prolonged hyperinsulinemic hypoglycemia, and the cause is due to the lack of the supply, depletion of the hepatic glycogen store, defective gluconeogenesis, transient hyperinsulinism due to transient regulation of the beta cell insulin secretion, increased sensitivity to the insulin, and there is no genetic cause in prolonged hyperinsulinemic hypoglycemia. And now going to discuss congenital hyperinsulinemia. The first one discussing diffuse. And diffuse is due to recessive inactivation mutation in ABCC8 and KCNJ11 gene are the most common cause of the congenital hyperinsulinemia, found in 15% of the patient, and it alters the function of the potassium ATP channel, causing unregulated insulin secretion. This results in severe congenital hyperinsulinemia, and this is unresponsive to potassium ATP potassium channel agonist, that is diazoxide. And histologically recessive form of the recessive channel mutation is characterized by large B cell with enlarged nuclei. And the milder form of the congenital hyperinsulinism are with the dominant inactivation mutation in ABCC8 and KCNJ11 gene. This milder form is also reported in mostly unresponsive to diazoxide. Both severe and milder form are unresponsive to diazoxide. And the focal form is due to the potassium channel mutation are confined to restricted the pancreas. Chromosome 11 E15.5 high maternally expressed tumor suppression, that is H19 and CDK1C, and paternally expressed growth factor gene, that is insulin growth factor 2, are close proximity to the potassium channel gene, that is 11p15.1. So during the development of the pancreas, when segmental paternal uniparental disomy occur as a somatic mutation, due to this mutation, KTPH potassium channel activity as well as also loss of the maternal expressed tumor suppression activity and gain of the paternal expressed insulin growth factor 2. So promoting of the growth of the abnormal B cell. And this is a main mechanism of the focal insulin. And histologically reveal a focal enlargement of the B cell with a large nuclei. And generally 96.2% of the focal lesions are unresponsive to diazoxide, but curable by the surgery. And I am already discussed. Both focal and diffuse and focal form, and then the GLUT1 gene mutation. It is sporadic inheritance, sporadic autosomal dominant, and additional feature are hyperammonia, epilepsy, recurrent hypoglycemia after protein-rich meal, and these are diazoxide responsive. In HADH gene mutation, inheritance are sporadic, moderate to severe hyperinsulinemic hypoglycemia. These are the diazoxide responsive. Glucokinase is autosomal dominant inheritance, and microsomia is a characteristic feature in glucokinase deficiency, and moderate to severe hyperinsulinemic hypoglycemia, and it also is diazoxide responsive. HNF4 alpha and 1 alpha autosomal recessive inheritance. Microsomia is a characteristic feature, moderate to severe hyperinsulinemic hypoglycemia, response to diazoxide and glucose infusion. And Beckwith-Wiedemann syndrome is imprinting disorder, and characteristic are microglossia, anterior abdominal wall defect, organomegaly, hemihypertrophy, earlobe freeze, helical pith, and renal tract anomaly. And it is also diazoxide responsive, and 5% cases are unresponsive to diazoxide. Now I'm going to discuss IM cause of the persistent hypoglycemia. This is liver glycogenosis, type 1 and type 3. Type 1 is due to glucose 6 phosphatase deficiency, and type 3 is due to debranching enzyme deficiency. A main symptom of growth retardation, hepatomegaly, hypoglycemia, elevated blood lactate, cholesterol, triglyceride, and uric acid level. And treatment are cornerstone meal, continue nocturnal nasogastric drip. Galactosemia due to defect in 3 enzymes, galactose 1 phosphate, uridyl transferase deficiency, galactokinase deficiency, uridine diphosphate, galactose 4 epimerase deficiency. Characteristic symptoms are vomiting, hepatomegaly, cataract, immunoaciduria, and failure to thrive. In glucokinase, there is cataract is additional feature, and epimerase deficiency, there is additional feature like hypertonia and nerve deafness. And galactose-free diet is main treatment. And this is gluconeogenesis, 2 enzymes involved in this pathway, fructose 6 phosphate and phosphoenol pyruvate carboxykinase. And main symptom like episodic hypoglycemia, apnea, and acidosis. And hypoglycemia, hepatomegaly, and hypertonia and failure to thrive is the main symptom of phosphoenol pyruvate carboxykinase deficiency. Fatty acid oxidation defect. There are multiple enzyme minimal fatty oxidation defect, and main symptom are recurrent episode of fasting hypoglycemia, coma, hypotonia, acrid color, and investigation treatment are acidosis, absence of ketone in urine, low carnitine level, TMS and enzyme assay, only more biopsy investigation of choice, carnitine supplementers, avoid fasting main treatment. Organic acidemia is multiple enzyme involved in organic acidemia, refusal to feed, vomiting, acidosis, neutropenia, and thrombocytopenia are main symptom. Elevated metabolite in TMS and GCMS. And the hormonal deficiency is mainly hypopituitary. Now I'm going to management portion. And detailed family history regarding infantile seizure, unexplained death, and diabetes are ruled out. And history of prenatal risk factors such as maternal diabetes, administration of the intrapartum hypoglycemia, birth asphyxia, fetal distress, and prematurity ruled out. On physical examination, identify who are the SG or LGA. Dysmorphic feature to rule out omphalocele hemihypertrophy microglossia, to rule out bacterial man syndrome. Evidence of hypopituitarism, that is lip cleft palate micropenis short stature, to rule out hypopituitarism. And for adrenal insufficiency, hyperpigmentation, and weight loss, specific feature of adrenal insufficiency to rule out. And disorder of gluconeogenesis, hepatosplenomegaly to rule out. So in severe hypoglycemia requiring abnormally high GR and persistent hypoglycemia despite adequate GAR, both in absence of prenatal risk factor and presence of syndromic risk factors, should promote an evaluation. And these infants should undergo critical laboratory testing at a time of hypoglycemic episode. And genetic analysis should be sent once the hyperinsulinemic hypoglycemia is confirmed. So in hypoglycemia, after checking the critical sample, if there is no acidosis and blood ketone and blood free fatty acid will be low, then we suspect the hyperinsulin. And when to draw the critical sample, and critical sample to when plasma glucose level less than 50 mg per dl, and in the critical sample, plasma beta hydroxybutyrate is less than 2 millimole per liter, plasma free fatty acid is less than 1.5 millimole per liter, and plasma insulin level greater than 2 unit per ml, along with the normal serum cortisol and normal growth hormone, to exclude the cortisol and growth hormone deficiency. If there is an increase in insulin greater than 2, plasma free fatty acid and plasma beta hydroxybutyrate is low, we suspect hyperinsulinemic hyperglycemia. And this is a flow diagram of the how to manage hypoglycemia. In hypoglycemia, blood glucose level is 25, and baby are symptomatic. Then go to the bolus 2 ml per kg, 10% dextrose, followed by the infusion at a rate of 6 mg per kg per minute. And if there is the blood sugar less than, after the starting the infusion, blood sugar is less than 50, gradually increase the GR at a rate up to the maximum 20 mg per kg per minute. If there is GR greater than 50 mg per kg per minute not controlling the hypoglycemia, then we suspect evaluation for the percent hypoglycemia. And this is a picture which drug dioxide will be act on the potassium channel, and octreotide will inhibit the calcium channel. Dioxide activate the channel, potassium channel, and octreotide inhibit the calcium channel. Now I come to dioxide. Dioxide inhibit the insulin release by acting as a specific ATP sensitive potassium channel agonist in a normal pancreatic beta cell, and those are 5 to 20 mg per kg per day at 8 to 12 hour interval. Initial dose is starting with 5 mg per kg per day and titrate based on response. Once the dioxide dose need to maintain normal glycemia at least 72 hours of life at below the 5 mg per kg per day, then we taper by the 1 mg per kg per day every 32 hours as tolerated. And if normoglycemia cannot be achieved after receiving a maximum dose of 5 subsequent day. It's called unresponsive to diazoxide. And side effects are fluid retention. So that is diuretics such as hydrochlorothiazide at rate of 5 to 50 milligram per kg per day, along with the diazoxide will be added to overcome the this fluid retention side effect. And chlorothiazide will also act as a synergetic with the diazoxide to suppress insulin secretion. And other side effects are hypotension, hyponatremia, hypertrichosis, thrombocytopenia. And this is the overall drug used in hypoglycemia. Hydrocortisone at a dose of 5 milligram per kg per day, IV into divided dose. Mechanism of action of these are reduced peripheral glucose utilization, increased gluconeogenesis, increased effect of glucagon, and adverse side effects are growth suppression, hypertension, hyperglycemia, GI perforation. And diazoxide already discussed. Diazoxide octreotide at dose are 5 to 25 microgram per kg per day, 6 to 8 hours subcutaneous IV infusion. Increment of the